Dear participants, dear students and young scientists at BIMCO 2025, hello to everyone. My name is Iliadi Tulbure Corina, and I'm Associate Professor at the Department of Obstetrics and Gynecology at the Nicolae Testemitanu State University of Medicine and Pharmacy from Chișinău, Republic of Moldova. And I'm also an obstetrician and gynecologist working at the Institute of Mother and Child in the same town, of course, in the same country. Thank you so much. You have invited us to share with you our experience about the simulation-based training in emergency obstetric conditions. It's such an honor to be here and to participate at BIMCO 2025. We know very well that simulation is a structured educational approach that replicates artificial events to achieve a high level of realism, particularly in the context of significant or rare clinical scenarios. We have two simulation centers in Chișinău in Moldova, and we are working also with students, with young doctors, nurses, and of course we are working with doctors in continuous education of different specialty and especially with obstetrician and gynecologists. We know that simulation represents a systematic process for acquiring knowledge and refining skills. We are trying to give to our trainees not only theoretical knowledge, but technical and non-technical skills, which can enhance the effective execution of anticipated tasks while fostering continuous learning and professional development. We know, of course, that simulation can be integrated into medical education that enhances competences, patient safety, and readiness for maternal and neonatal emergencies. Obstetrics and gynecologist as specialist is working not only with one patient, which is the mother or pregnant woman, but also with one or several fetuses located in the uterine cavities. That is why it's so important to pay attention and to work with in both activities in both directions. Simulation also can strengthen practical skills, case management, self-assessment, protocols applications, and crisis response. Actually, when we are simulating and working in real life with clinical cases, we have to work in a major crisis situation on a major stress, and we have to work according to some international or national protocols. And we are trying during simulation to teach our trainees how to apply this. At the moment, at Nicolae Testemitanu State University of Medicine and Pharmacy in Chișinău in Moldova, we have almost 6,000 students, national and international. We have also 400 Ph.D. students in different specialties, also residence doctors, and almost 5,700 trainee doctors and pharmacists in continuous education. It's quite a number. That is why it's so important to implement simulation not only for young doctors, but also in continuous education for our doctors and for our pharmacists, and of course in continuous educations not only at our universities, but also in some hospitals. At the moment in the Republic of Moldova, we have two centers of simulation. The one is named CUSIM, which is in translation is University Center of Simulation in Medicine. And this center is actually directly linked to our university, and we have different kind of simulations there with young doctors and with students. But we have another center located in the tertiary perinatal center named Institute of Mother and Child. And in that simulation center, we are working actually with multidisciplinary scenarios. We have a lot of interesting and more complex and comprehensive simulation scenarios, and we are working with doctors and nurses. We have also different obstetric emergencies, and we have different scenarios. We used to propose different scenarios in hypertensive disorders of pregnancy, also in fetal hypoxia, vacuum extraction, breech presentation, and postpartum hemorrhage. We know very well that hypertensive disorders of pregnancy is a frequent condition during pregnancy, which can occur over the 20 weeks of gestation when the blood pressure is over 140 and 100 millimeter of hydrargyrum. And when we have preeclampsia, is also associated the level of blood pressure over 160 systolic 1 and 110 diastolic 1, associated with some neurological symptoms, and of course with proteinuria during the 24 hours. When we have eclampsia, we have preeclampsia associated with some convulsions, and HELP syndrome we can determine in case of preeclampsia or eclampsia and some disturbances in biochemical lab test. We used to perform fetal hypoxia as scenario, having two directions, two scenarios actually. One is when fetal heart beating or fetal heart rate is over 180 beats per minute situation, or the first phase of hypoxia named tachycardia. And another sub-scenario is when we have a bradycardia, which is the situation when the fetal heart rate is less than 110 beats per minute. In this case, we have to perform vacuum extraction of a fetus through vaginal delivery, or maybe to decide about some indications for emergency section. Also, we have a bridge presentation as scenario, and in this case, we ask our trainees to think about the diagnosis of different type of bridge presentation, and also to decide about the indications for C-sections. And probably postpartum hemorrhage is one of the most complex scenario. It's the condition when we have a bleeding over 500 milliliters after a vaginal delivery, or more or over 1,000 milliliters after C-section, which enhance and need a more comprehensive multidisciplinary approach. There are some core characteristics of simulation. The first one is risk-free learning environment. Learners can make mistakes during simulation and refine their techniques without endangering patient safety. And you know how important in this period is to maintain patient safety, and how important is to make some mistakes, but not in real life, but in simulation. The second one is about the realistic patient encounters. All simulated scenarios range from routine clinical cases, which are more frequently and less complex, to some complex obstetrics emergencies, ensuring comprehensive training. And in that case, we will have, of course, a multidisciplinary teams, and of course, we will have a more comprehensive approach. The third core characteristic is immediate feedback and assessment. In that case, students receive a structured feedback and a structured assessment, and this is needed to reinforce learning and highlight different directions for improvement, not only for some clinical parts, theoretical knowledge, but of course for technical and non-technical skills. And it's so important to repeat skills all the time to develop it, because we know very well the Latin sentence repetitio est mater studiorum, which means in English, repetition is the mother of learning. And it's really important that to do so during the simulation, because it can reinforce memory and improves proficiency in obstetric interventions. In simulations, we have three stages or phases. It's about briefing, simulation, or debriefing. In case of debriefing, as trainers, we used to give some basic information about the clinical case or about the patient. It's all the time the information about the age, the situation, clinical symptoms, and of course about the gestational age and mix of gestation. In case of simulation, we have different clinical cases as scenarios, basic ones, frequent one, or maybe rare. And in case of debriefing is one of the most critical components of medical simulation-based education. We propose to our trainees and we discuss about what just did happen, or we used to speak about their emotional feelings. And debriefing, it's really important because it can transform the simulation experience from just doing into something really deep, in deep learning and reflective practice. As debriefing, there are some characteristics, and we use to give a structured and guided process of debriefing. And we used to speak, of course, first of all, about reactions, because emotional processing of the debriefing and simulation is so important. Then we propose to analyze by critical thinking and reflections all the activities and all the procedures. And after that, there is the third part, which is summary, and we recommend as trainers how to deal with this situation in another simulation or in real time. In this case, we used to give or to recommend how to apply some theoretical knowledge or some practical skills in real life. Debriefing should be safe learning environment, should be evidence-based discussion, and should be focused not on persons but on performance gaps. All this is so all important because it can reinforce learning objectives of simulation. There are different approach, or maybe one of the most critical and the most classical approach of debriefing, which is a debriefing with good judgment, or the advocacy inquiry layer cake. We should figure out that the debriefing is like a cake, and there are 3 layers. The bottom layer is about what happened. There are some observable facts during the simulation. The middle layer is about how to facilitate and how to explain to our trainees different perspectives and how to learn them to make some advocacy about their actions and about the procedures, and to involve, of course, the critical thinking. And the top layer is to invite the learners and to give them some recommendations for perspective thinking. The importance of debriefing is known, again, very well, because it can promote deep learning, enhance clinical reasoning, can improve future performances, develop not only clinical, but of course, technical and non-technical skills. And the most important ones can be communication, team building, learning during and communication during simulation, and of course, leadership. Also, debriefing can help to reduce errors in real practice and support emotional processing of simulation in itself. The key benefits of simulation is about enhancing decision-making and critical thinking. Trainees learn to make quick decision and evidence-based decision under major pressure, because obstetric emergencies are developing during or under major pressure. It also improves communication and teamwork. If you have a situation or complex simulation cases or scenarios, it can involve multidisciplinary teams. In case of obstetric emergencies, we can have several teams. One team can be presented by obstetricians and gynecologists and by midwives. Another one can be represented by neonatologists and nurses in neonatology and pediatrics, and another one can be presented by 1 or 2 doctors in anesthesiology, and of course 1 or 2 nurses. That is why it's so important to work and to improve communications not only in the same team, but between the teams. And we have also one of the most important team consisting from our patient and the baby, the fetus, and of course, health relatives. Another benefits of simulation is about reducing medical errors to boost confidence, and it's so important to develop and to perform simulation in a safety environment, which can enable learners to practice high-risk scenarios without jeopardizing patient health. And it's, of course, simulation represents an evidence-based learning, because studies show improved clinical outcomes and decision-making abilities in students and young doctors trained through simulation. And we are trying to do so each year, and not only for young specialists, but for our doctors in continuous education. During the simulation, we are trying to give some perspectives and some directions as theoretical knowledge especially by fortifying it, practical skills by fortifying and acquiring, and non-technical skills as communications and leadership and team building. We are trying to give a cognitive model to develop a mental pattern, of course, to make some practical performances. We are actually doing an activity divided in 4 phases. First is when the trainer is doing or performing an activity. The second one is about when the trainer is doing something, performing and explaining in the meantime. The third one is when the trainees or the one trainee is performing and explaining. And the fourth stage is when the trainee is only performing and showing the performance for the members of the team. We know that we have 4 types, or maybe more than 4 types of simulation. The first one is task trainers, mannequin-based simulation, standardized patients, and virtual simulation. Here in Moldova, we use the first 3 types, and we are trying to do our best to implement in the next year virtual simulation, which is a computer-generated scenarios that allow interactive learning. And of course, for young generation, the 4th type is the best one and more interactive. When we are speaking about the task trainers, we have some anatomical models for practicing basic specific skills. In obstetric scenarios, we have different type of basic skills. We used to teach our trainees and young doctors and students how to take properly the blood pressure, how to diagnose hypertensive disorders during pregnancy, how to appreciate and diagnose preeclampsia, how to determine the fetal heart rate, and to establish fetal disturbances determined by tachycardia and bradycardia. Another basic skill is about the determination of contractions and establish if woman is in her labor. We have another type of skills, basic skills. Our trainees can learn about the determination of proper, normal, or pathological presentation of the baby, of the fetus, and of course, the determination of gestational age. When you have a mannequin-based simulation type, we use high-fidelity mannequins which can simulate human responses as breathing, heart beating, labor contractions, and in this case, we have multidisciplinary scenarios, and we use this type of scenarios in the simulation center located in Institute of Mother and Child, having 3 or 4 types of teams. In case of objective structured clinical examination, we use standardized patients, and trained actors in this case simulate real patient cases to enhance diagnostic and communication skills. In this type of simulation, is important not only to practice something and to show some theoretical knowledge and practical skills, but also to develop communication with the patient and the member of the team. We know very well that in all simulation cases, we are dealing with such a stressful situation. And through simulation, we teach our trainees and our young specialists how to deal with this situation, how to effectively work under the major stress, how to discuss and communicate in that time with patient and their relatives. And we are trying to explain the situation and the procedure to the trainees, and we used to ask them to do so with the patient and their relatives. And in the same time, they have to remain calm. To achieve this, each of our trainee has to know about the Edward de Bono 6 thinking hats as a tool and as a structured problem solving in the medical crisis. This process is similar to virtually wearing for a certain time a hat of a particular color. We have 6 types of hats and colors. The white one is about the facts and patient data. The red one is about the emotional response and management. The black is about identifying risk. The yellow one comes with optimism and benefits. The green one is about the creative solutions and options. And the blue one is actually the debriefing, is about the coordination and decision making. Through the simulation or during the simulation, we have different emotional activities or directions. And when we have a white hat, is about facts and patient. In this case, our students or doctors do have information about the age of a patient, and we know that the reproductive age of our patient in obstetrics is between 15 and 49 years old. They have to know about the parity, the gestational age and weeks of gestation, because again, they have to know they are dealing with miscarriage, early or late one, or maybe with premature birth, or maybe they have a birth at term. In that situation, there are some different symptoms, and according to these symptoms or clinical signs, our trainees have to know and which are the proper criteria to establish a diagnosis. And in this period, or according to this white hat, they have to assess the maternal vital signs as pulse, blood pressure, temperature, and they have to know and they have to assess also the fetal well-being by determining fetal movement, fetal heart rate, etc. They have to know about the medical history, because it's really important to know not only about the obstetric and gynecological history, but to know what kind of surgery did the patient have in earlier. In this moment, our trainees have to decide about the diagnosis or to have some criteria to establish the proper diagnosis. When we have a situation, we can have a situation during simulation or in our real life when we have an emotional response to management. It's a stressful situation, as I told previously, and it should, the duration should be less than 30 seconds. In that moment, we have some stressful situation, and we have to think about some possible major complications or risk for the mother and for the fetus. And of course, a management plan needs to be decided. In black hat, or when we are wearing a black hat during the simulation, we have to identify some risks. We can have some negative thoughts and comments. We can have a situation when we have to identify some causes of failure. We have to ask about maybe some can recurrent seizures be ruled out, or maybe we need to decide about another treatment, etc. Maybe we have some situation of bleeding during pregnancy or during the birth. In this case, we just have to monitor the maternal and fetal state, and we have to decide maybe about the indications for C-sections. As I told previously, yellow hat is coming with optimistic and thoughts, positive thoughts, and some benefits. In this case, or at this moment, we have to search for a solution or advantages, and we have benefits. The first benefits that we have, we know already the diagnosis, we have the symptoms, and we can assess the maternal and the fetal conditions. At this moment, we can use maternal vital signs, and of course, if you have enough time, we can use ultrasound exam to assess and to determine the fetal well-being. At that moment, we have a diagnosis, and we have to appreciate the management according to our national or to our international guidelines. The green hat create new ideas and approaches, and maybe at this point we have to decide about some different perspective on the problem. Maybe we have to pay attention at some additional symptoms. Maybe we have to change a little bit the criteria for the diagnosis, and maybe at this moment we have to change the diagnosis itself. In that situation, at that moment, we have already the stabilization of the maternal and fetal conditions, and we have to decide on 3 directions: about the admission of patient in the obstetric unit, maybe about the delivery and the criteria for the extraction of the baby through C-section. And the last but not the least stage is about the coordination and about the decision making. We have actually debriefing, the assessment of maternal well-being and or fetal well-being. We can explore some alternatives at that moment to assess prognosis and to give some recommendations about ongoing pregnancy or about an emergency section with some specific indications and criteria. And at that moment, we should discuss in our team about the management according to international or national guidelines. Simulation is about the teamwork, and we have to pay attention on each emotional state of each member of the team. And of course, it's so important to ask for help because we are working in a team and we have to do properly our activity together. As I told you, one of the most complex scenario can be about the management of immediate period of immediate postpartum hemorrhage. That is why we decided to speak about one of this type of scenario.
Hello, dear colleagues. My name is CEMORTAN Maria, and I am assistant professor at the Department of Obstetrics and Gynecology. I'm Ph.D. And now we are going through the scenario that is entitled Managing Immediate Postpartum Hemorrhage Following the Vaginal Delivery. This case is designed to stimulate one of the most critical emergencies in obstetrics, the postpartum hemorrhage, PPH, which can rapidly escalate and request prompt, coordinated team intervention. So we are going to see the key components we'll focus on during the simulation, and we will start with the learning objectives, the skills, what we are expecting to develop by the end of the simulation. So we need to identify the early signs of postpartum hemorrhage, to apply the initial management protocol, to demonstrate effective team communication and leadership, to initiate appropriate medical and surgical interventions, to understand the emotional and psychological aspects, to apply SBA communication under the pressure, and to reflect on individual and team performance during the debriefing. At the next stage, we should discuss the equipment and the setup for the tools and simulation environment that will support our learning. And usually we need an obstetric mannequin, simulated vital signs monitor, blood loss collection system, uterine model, intravenous lines, fluids, uterotonics, Bakri balloon, suture materials, catheter, and the observation room with audio and video. We will discuss the team roles, and we need a primary obstetrician, a midwife or a nurse, assistant doctor or a resident, an anesthesiologist, so they are all learners and co-learners, and observers and an instructor. We will go through the briefing, the pre-simulation, and we are discussing the situation. So you are on call on obstetrician gynecologist team attending a vaginal delivery in a healthy 27-year-old second period woman. The baby was born 10 minutes ago with good EPGAR scores. And now you are responsible to monitor the third stage of the labor and immediate postpartum period. So on this stage, we should remind learners that this is a safe learning space, mistakes are part of the learning, and team communication and reflection are essential. So we begin with the routine situation. A woman has just delivered a healthy baby, so her initial vital signs are stable: blood pressure 120 to 80, heart rate 19, uterine fundus is firm, and mild vaginal bleeding appears normal with normal limits. This phase sets the clinical baseline and allows learners to get comfortable with the environment and team dynamics. So we are going further, and over the next 10 minutes, things change. The vaginal bleeding becomes significant over the 800 milliliters, and the uterus becomes soft and boggy on palpation. The vital signs became deteriorate, so BP 95 to 60. Her heart rate raises to 115, and respiratory rate increases to 24. The patient is pale and anxious. And at this point, the learners must recognize that we are dealing with the postpartum hemorrhage, and the key points that are expected during this phase are calling for additional help, initiating the uterine message, administrating the oxytocin, establishing the large bore intravenous catheter, and start fluid resuscitation. Request blood products, and keep in mind that simulated delay will occur. Catheterizing the bladder, and beginning to rule out retaining placenta or vaginal trauma. So we are going to the next stage, and in this stage, the first line interventions fail. In this case, become more complex, and uterotonics are ineffective. So the next step is to consider tranexamic acid, and if the bleeding persists, the scenario introduce the advanced interventions such as placing the Bakri balloon or preparing for surgical management. And the critical actions during this stage include escalating to the senior staff, cooperating with the team for operating room preparation, maintaining clear and structured communication using SBAR, especially with the colonies, and continually reassessing the patient's vital signs and uterine tone. So this phased approach allows learners to experience the natural progression of a PPH emergency, respond in real time, and build both confidence and competence in managing high-risk obstetric situations. Now we are going further to one of the most important stages of the simulation, like debriefing. And first we start by checking on emotional experience. This helps to normalize stress response and to open the space for honest reflection. Next, we drive to clinical and communication analysis. So let's reflect on decision making. We will explore team communication and also reflect on how well emotional support and teamwork were integrated during the emergency. Finally, we summarize the key learning points, and the debrief is not about judging, it's about learning and improving both our clinical practice and how we function as a team under the pressure. Through the scenario, we could clearly see how timely communication makes difference. And in high-pressure situations like PPH, even the most advanced clinical skills can fall short without strongly communication.
Hi, I'm Milena, a sixth-year medical student at Nicolae Testemitanu State University, and I'd like to speak about communication as the most influential factor in provision of healthcare that affects all aspects of care delivery, from professional performance of skills to patient safety. The nature of communication is in itself complicated, as it encompasses aspects of culture, language, and nonverbal skills, and within healthcare communication, extra stress can adversely impact the ability of an individual to communicate effectively. Communication errors have a negative impact on patient safety. Several studies have demonstrated that inadequate information sharing due to healthcare professionals' hesitancy to speak up leads to adverse patient outcomes. That's why Effective communication and teamwork is essential for the delivery of high-quality patient care. Simulation-based training is a proven method enhancing both technical and non-technical skills. In obstetric emergencies, communication is a critical non-technical skill that improves patient safety, team performance, and response time. The complexity of medical care and human limitations make it essential for clinicians to use standardized communication tools, foster an environment where concerns can be voiced, and adopt a shared critical language to signal unsafe situations. There are some types of communication tools that has proven to have a positive effect on communication. First one is SBAR, which stands for Situation, Background, Assessment, and Recommendation. Firstly, you begin with the situation where you clearly state what is happening at the moment and why you are communicating. This helps your listener quickly understand the urgency or relevance of the case. Next comes the background, which includes any relevant clinical information or history that provides context to the current situation. This step ensures that the listener has all the necessary background to fully understand the patient's status. Following this is the assessment, where you explain what you believe the problem is based on your observations and clinical judgment. This part allows you to share your interpretation of the data and helps guide decision making. Finally, you end with the recommendation, in which you suggest what needs to be done or what action you propose to address the problem. This could include specific interventions, further investigations, or consultations. Closed loop communication is a communication technique where information is sent, received, confirmed, and verified to ensure accuracy and prevent errors. Sender gives a clear message or order. Receiver repeats back the message to confirm understanding, and sender confirms the accuracy of the repeat back or corrects it. Checkbacks is a technique where the receiver repeats the information to confirm correct understanding, validates that critical information was received accurately, and callouts, a strategy used to communicate critical information loudly and clearly during high stress or emergency situations to the entire team. Ensures that everyone on the team hears and understands key information simultaneously, promoting situational awareness. And last, debriefing is a two-way discussion between facilitator and student, most often held at the end of a simulation session. The aim is to hold a conversation whereby the facilitator guides learning and reflection so the team can learn both from themselves and one another. Effective communication is a scientifically proven cornerstone of safe obstetric emergency care. Simulation-based training equips students with essential communication skills for better team performance and patient safety. It improves maternal and neonatal safety, builds confidence for clinical practice, enhances team coordination and role clarity, reduces medical errors and delays, improves decision-making under pressure, promotes psychological safety and speaking up, and strengthens interprofessional collaboration. Next, my colleague will now continue by presenting the findings of the study we conducted on obstetric simulation, where we explored its impact on clinical decision-making and teamwork during emergency scenarios.
So last year, we conducted a study which aimed to assess the importance of simulation-based training, multidisciplinary teamwork, and communication in the management of obstetric emergencies. Thus, it comprised a comprehensive approach where the principle of at the patient's bedside remains fundamental. The primary focus was on the educational aspect, allowing for mistakes during training, but ensuring that medical assistance always leads to a positive outcome. Subsequently, each session was consolidated by a three-stage educational approach, where the first one was an initial attempt to task performance, second, a collaborative feedback and development of recommendation, and last but not least, a final task completion based on refined strategies. As we precedently discussed, every simulation is composed by briefing, simulation, and debriefing stages. In our study, the trainees encountered the 5 phases of teamwork. That being said, the forming, the storming, the norming, the performing, and the adjourning stage. The forming stage means the formation of the team when the members come along to create the team. The storming stage is the phase where the trainees discover the real difficulty of the teamwork. The norming stage occurs when they get over the difficulty encountered before, and they begin to become functionally efficient. The performing stage is the stage where the peak performance is present in their interactions. And last but not least, the adjourning stage, when the team breaks up, when the required task is complete. A stunning 94.9% of them express their need to provide emotional support to other colleagues participating in the scenario. All of our participants noted that the proposed scenarios were well adapted, where 96.2% of them emphasized that simulation is an important educational process in obstetric emergencies. Also, the participants noted that simulation is a valuable tool for maintaining a high level of professional preparedness in this field, where 87.2% of participants stated they would try to implement the acquired knowledge and skills in their workplace and apply them in practice. And now analyzing the model of the teamwork, or in other words, the leadership, where the leader is the individual who influences, guides, and motivates the others toward achieving a common goal. We know we had an effective leadership because they involved the ability to communicate a clear vision, to make informed decisions. They also included foster collaboration, and they really adapted to the challenges. Why leaders play a crucial role in their team? It's because they shape their team's dynamics, they promote accountability, and they cultivate an environment where individuals can perform at their best. And finally, the base of all teams, the communication, which is the process of exchanging information, ideas, emotions, and intentions between individuals or groups through verbal, nonverbal, written, or visual means. An effective communication involves not only the transmission of a message, but also its accurate reception, interpretation, and response. We know that it's a fundamental skill in building relationships, coordinating actions, and ensuring mutual understanding in personal, professional, and organizational contexts. And in conclusion, our simulation enabled the training of teamwork and decision-making in emergency obstetric situation to ensure patient safety. It was presented as an educational game that aimed at developing new skills, reinforcing ones, and enhancing them further. It was described by our trainees as a positive experience that should be repeated at least once a year as a model of continuous education. And last but not least, it enhances competence both in application of specific skills and in communication.
Well, we have some take-home messages for all participants, and simulation is an effective method for medical professional training. Also, simulation-based training improves teamwork, decision-making, and patient safety in obstetric emergencies. And simulation develops new skills, refines existing ones, and enhances technical and communication competency, recommended for continuous education, not only for young students, for young specialists, but also for doctors and nurses in continuous education. We'd like to finish with such a sentence: educational games provide the kind of practice that nothing else can. That is why our team suggests to continue to play this game because simulation is one of the most important games in medicine. Thank you so much for your attention. And of course, we wish to all participants to have a nice BIMCO 2025 Congress. Thank you so much.